last two episodes of this show, we focused on the gains and challenges so far in the health sector 3 years after devolution. Now, across counties, one of the challenges that have been cited is inadequate funding. And you may be asking, just how big is the problem? How much funding goes into the health sector at both the national and county levels?
80% of that departmental budget, health department, goes to salaries.
This allocation is so difficult to run the health services.
And the other question is, the money that is set aside for health services, is it being put to proper use?
There's a lot of wastage in the system.
The stealing in Nairobi is mega. The stealing in the counties is a baby.
Also in this show, the forthcoming third annual devolution conference to take place in Meru. What is in store for Kenyans? Welcome to the show. I'm your host, Alex Chamwada. Since the inception of the devolved government, just how much money has been pumped into the counties through the equitable allocations? During the State of the Nation address on 31st March 2016, President Uhuru Kenyatta said that the government had so far transferred 1 trillion shillings to county governments. The Commission on Revenue Allocation says this is not the case.
190 at the beginning, that's year one. I can add for you 190. Then there was 230. Then this year is 260. It is 680 billion.
The national government still gets the bigger share.
The shareable revenue, they are getting 33%. 33%, but that is the revenue for the audited accounts, which is 2013, 2014. It's a little back. So if you come on the year we are in, it's about 20%. For every 100 shillings that KRA collects, 20 is given to counties. 80 shillings is kept by national government, which is still a lot of money. But we cannot expect an overnight change. We've got to restructure the national government so that we reduce the administration.
No, you need to go back to the issue of shared revenue. So whatever remains of national government is shared across ministries. But if you look at Ministry of Health, we have major parastatals, Kenyatta Hospital, Moi Referral, NHIF, KEMSA, and so on. So all this, the money may look a lot, but it's not. The money is going to these parastatals. You also have regulatory bodies that we take care of. Nursing Council, medical boards, lab boards, and so on, many other boards. So the perception is that there's a lot of money remaining. No, it's not true. We still need, for example, strategic commodities for HIV, TB, malaria. Those are vaccines, those are centralized. For obvious reasons, these are very strategic commodities that we need to ensure they're always available so that they're not tied up to the inefficiency of anybody in the system. So we always procure all the vaccine. We use about 5 billion shillings for vaccine. We're using about 22 billion shillings for ARVs. Anti-malarials are also included and so on.
Then there is the Equalization Fund targeting previously under-resourced areas. The National Treasury allocated the fund 3.4 billion shillings in the 2014-2015 financial year, 6 billion shillings in 2015-2016, and currently a proposal of 6 billion shillings.
It's our role to identify which counties are marginalized, and we have identified 14. It's actually the national government who should spend the money. And Treasury has taken a rather long time to come up with the process of spending that money. So really, the issue is the Treasury. It is unfortunate it has taken too long.
When it comes to allocations to the health sector, the combined figure for both the national and county governments was 5.5% of the national budget in 2013-2014, and this increased to 7.5% in 2014-2015. A year before devolution, the allocation was 7.8%. Yet, African leaders agreed in Abuja in 2001 that governments should be allocating 15% of their national budgets to the health sector.
If you look at the total health expenditure, from government, private sector, insurance, plus out-of-pocket expenditure, we are talking something close to 240 billion annually. That's a lot of money. And if you look at per capita expenditure in Kenya, we are talking close to around 7,000 shillings per person per year. Again, it was recommended by WHO, basically $66, which 6,600 or thereabout. So we are spending much more than even recommended globally. Now, the problem, people ask, why so much money? Yet the impact is not felt everywhere. The kind of money coming into the system. And between us and county government, national government, county government, we're talking about 120 billion shillings annually now going in the sector. The problem is inefficiencies in the system.
We've got to work very hard. You have heard over and over that 30% of national budget is stolen through corruption. The stealing in Nairobi is mega. The stealing in the counties is a baby. So there's a lot of effort by the president, which is commendable, the anti-corruption, to try and reduce wastage and stealing of public money.
So while the total money pumped into the health sector appears huge, the reality on the ground, if we narrow down to only funds spent by county governments on health, is this. On average, the money allocated per person for health at county level is only about 1,500 Kenya shillings, going by the 2014-2015 financial year analysis.
Yeah, they should be spending much more. But even those who are spending 1,500, they could get more value from that money if they address wastage. Do we buy drugs, right drugs? Are we getting drugs the right price? Are we managing our operation cost? Do all health workers give us the 8 hours per day required? And so on. So there's a lot of wastage in the system that even the little we put, we can get much more money from the system. But overall, we have seen progress in how we manage our resources. We have seen more money come into the system, which is good. We only need to tighten up. And of course, the whole issue of this out-of-pocket expenditure is leading what we call catastrophic expenditure on health. People are becoming poorer when they pay out-of-pocket expenditure. So there are a number of issues we need to address as a country to ask ourselves, this is 240 billion shillings coming to the health sector. Is there a better way of managing that money? Can we risk pool together? So that when you're able to, we're talking about insurance cover. So risk pool is about insurance. And that is why we are very keen on National Health Insurance Fund to be functional. So that we have more and more Kenyans being insured. We are now close to 6 million people covered by NHIF. And if you multiply that by number of beneficiaries, around 4, we are close to over 20 million people having an insurance cover.
So how are the county governments spending the money on health? Pick Vihiga County, for example.
In the last financial year, 20% of the county budget went to health. But when you look at that 20% of the county budget, 80% of that departmental budget, health department, goes to salaries.
The justification put forward by county health chiefs is that the health sector is labor intensive.
Staff are required at every service point, right from the dispensary to the level 5. It's not like a Ministry of Agriculture where you'll want an extension officer to cover a whole ward or a district. But for healthcare, you need adequate numbers of staff to match the many patients who are coming in.
Out of the 1.7 billion that we were allocated, leave alone requisite development ratio of 30% to go to development expenditure. Out of the 1.7 billion, 75.5% went to salaries alone. It leaves us 400 million shillings, out of which we are supposed to buy the commodities and supplies, which is a very key ingredient in service delivery, because we are talking about the drugs, which are basic. We are talking about the non-pharmaceuticals, which a nurse cannot do without or a medic cannot do without. Operational expenses are so heavy in the Ministry of Health.
Our biggest problem is that it's like we woke up one day and decided from today, health is completely devolved. We probably needed to put milestones and roll it out progressively. The biggest difficulty has been the management of the human resource for health. It would be very important for somebody perhaps to design a way of sharing this manpower. What I mean by sharing is counties can pool their resources together, those that are have proximity to one another. And let's say this specialist can then be at some place that is accessible, and they still offer services on an agreed terms for these counties.
The policy we have is that any Kenyan should not walk more than 5 kilometers from their house before they're able to reach a health facility, a public health facility, a 5-kilometer radius. So roughly that is a 30 minutes walk. I'm glad to say in many areas that policy have been met, which is good. The challenge now we have is basically how to improve quality of care. How to ensure you have enough health workers in this facility? How to ensure that you have equipment? How to ensure you have drugs?
One major source of income is own revenue, which we are really impressing on the counties. You must go out of your way to raise your own revenues. One major revenue is property taxes or property rates. So the likes of Kiambu has done a very commendable job. They have doubled their revenues. County like Machakos have done the same. The county of Kericho, the county of Nakuru, Mombasa. These people have really improved their own revenues. That helps. So own revenue, you raise your own revenue, you allocate some to health.
We also budget 4.2 billion shillings for free maternity.
Since October 2014, this money has never come.
We take a short break. Stay tuned for more on funding health.